I know they were so excited about it. They're white. They're just like you said, they're white, like creamy, kind of translucent. Once a year is all of us.
So we're going to go ahead and get started, and we'll thank you all for being here for our hospital topics, speed dating approach. Our first speaker from 4 will be Dr. Collins. And Laguna Beach, you can hear us okay? Assume they can. All right, Dr.
Thank you
the
very
floor
much.
is yours.
All right, so a guy goes to the doctor, and the doc examines him, and he says, well, you're in great shape. How old did you say you were? And the guy says, I'm 72. And the doc says, I don't think I've ever seen anybody your age in the shape that you're in. He said, how old was your father when he died? And the guy gets upset. He says, I never said my father died. And the doc says, how old is your dad? And he says, my pop's 95. And the doc says, that's great, that bodes well for you. How about your grandpa? How old was he when he died? And the guy gets pissed. He said, I never said my grandpa died. And the doc says, well, geez, how old is your grandpa? And the guy says, my grandpa's 115 years old. In fact, he's getting married next week. And the doc says, that's amazing. It was 115. Why does he want to get married? The guy says, I never said he wanted to get married. All right, we only got 12 minutes, so we got to go. People never, when you ask people if they drink, don't ask them how much they drink. Because everybody drinks more than they say they drink. Everybody in this room drinks more than they say they drink. So I always ask patients, do you drink? And they say yes or no. If they say yes, I say, what's your drink? I don't ask how many drinks you drink. If they say beer, usually a beer is a beer. I mean, nowadays you got 20-ounce beers and 24-ounce beers, but usually a beer is a beer. But if they say beer, I say a 6-pack or a 12-pack. And sometimes they say, Doc, no, I drink 2 beers a day. I said, okay. But sometimes you say a 6-pack or a 12, and then they say, oh, 6, you know, and usually that's accurate. Wine is almost as accurate as beer, but everybody knows we pour generous wine glasses. The real thing is mixed drinks. Nobody pours a drink when they pour a drink. None of us in this room, whenever I pour a drink at home, I use a shot glass. And the reason why I do that is because I've been asking my patients to use a shot glass for years, because the truth is, when you pour a drink, you usually pour it heavy. So I always ask my patients what their drink is, and then when they say rum and Diet Coke, I say, when you pour a drink, is it 2 shots or 3? And they go, what? I go, well, you use a shot glass, right? And they usually say no. And I said, well, when you pour it, is it like this? Is it like this? He goes, yeah, somewhere in the middle of that. And I said, well, just so you understand, when you have a drink, really you're having 2 drinks. And sometimes, depending on where they go, I say you're having 3 drinks. So when they say 3 drinks a night, it's actually 9. And I only say that because I want them to own how much they drink. So, you know, if your drink is not a glass of wine or a beer, then you should use a shot glass, and you should own how much you drink. 14% of the people have an alcohol use disorder. Up to 40% of hospitalized patients are alcoholics. So the mechanism of alcohol withdrawal is GABA. GABA is the major inhibitory neurotransmitter in the brain. Alcohol enhances GABA and blocks excitatory amino acids like glutamate. And then when alcohol blocks, for example, glutamate binding to NMDA, how the body reacts to that, how the body compensates for that, is it upregulates the glutamate receptors. And the problem that then happens when all these glutamate receptors are upregulated is once that homeostasis is established, only chronic alcohol use will keep that homeostasis. And when you stop drinking, suddenly then you have unchecked excitation and you have alcohol withdrawal. As alcohol tolerance develops, arousal is maintained at levels that would produce lethargy or coma in alcohol-naive individuals. My dad drank 18 beers a day. He would wake up and have a beer, he would go to the factory, he would stop at the pitcher, at the bar at lunchtime and drink a pitcher. On the way home he would stop and drink a pitcher. At home he would drink 2 beers for dinner and then he would go to bed. And I never ever, my whole life, remember my dad being drunk, but I bet that his alcohol level was always 0.2 or 0.3 or whatever. So when people drink that much regularly, and we all have patients that say they drink, you know, a half gallon or a gallon of vodka a day, all these people seem perfectly functional when their alcohol level would put us all on, you know, under the table. Symptoms of alcohol withdrawal. Minor symptoms usually start within 6 hours. Withdrawal seizures can start, again, as early as 6 hours. Alcoholic hallucinosis, which is not the same as DTs, and we'll cover that, can start as early as 12 hours, and DTs usually 2 to 4 days. The symptoms, the minor symptoms of withdrawal are pretty self-evident: tremorlessness, anxiety, nausea, no appetite, sweating, palpitations. Withdrawal seizures are usually Singular. They usually just have one seizure. They start within 6 to 12 hours after quitting alcohol. We get patients at Laguna all the time that fake seizures to get benzos. So, just common sense, right? Did they bite their tongue? Did they pee themselves? Are they post-ictal afterwards? Is their seizure symmetrical? Try and pay attention to that. These generally do not need to be treated with anticonvulsants. And status is distinctly uncommon with alcohol withdrawal, so if they're in status, you should look for another explanation other than alcohol withdrawal. Sorry for the eye there. Alcoholic hallucinosis is not synonymous with DTs. These usually start 12 to 24 hours after cessation of alcohol. They're usually visual. Formication, one of my favorite words. That's the hallucination that bugs are crawling on you. So formication. Patients are usually awake and alert when they have these visual hallucinations. So not only are they cognizant of the hallucinations, they're usually bothered by them. And as opposed to somebody who's hallucinating in DTs who isn't bothered by anything. They're actually bothersome to us, but they're not bothered by anything. DTs, 2 to 4 days after they quit drinking. This is only about 5% of people who go through alcohol withdrawal that will actually go on to get DTs. They're disoriented, they're tacky, hyperthermic, hypertensive, they're agitated, they're sweating. Again, they can have hallucinations, and this can last anywhere from 1 to 5 days. Who's likely to have DTs? People over 30, and it's over 30 because most of our patients that we treat pretty regularly for alcohol withdrawal started drinking when they were 13. So by the time they're 30, they're pros at drinking. They've been drinking for 10 or for 15 years. People who have a history of withdrawal seizures or withdrawal symptoms are more likely to have DTs. People who have withdrawal symptoms when their alcohol level is still pretty generous are more likely to have complicated withdrawals or DTs. And this is an odd stat. People whose withdrawal symptoms don't start for 48 hours or longer are more likely to then have complicated withdrawals with the withdrawal that they do have. There are some scores that you can look at that will predict if you're going to have complicated withdrawal or DTs. So the audit score, each of the top 3 lines is graded on a 0 to 4 scale. How many times you have had alcohol in the last year? How many drinks do you drink per day when you do drink? And that's between 0 and 10. And depending on where you fall, either 0 or more than 10, you get a score that's between 0 and 4. How many times have you had 6 or more drinks on one occasion? Again, depending on how many times you answered that question, you get a score from 0 to 4. And out of the 12 possible points, if you have 4 or higher than 4, it's a positive score. And it's 90% sensitive and specific for predicting withdrawals. The pause scale also predicts either complicated withdrawals or DTs. And it's the same idea. Each one of these things is 1 point. Alcohol within the last 30 days. Withdrawal and DTs are separate. Each one gets a point. Rehab and blackouts are separate. Each one gets a point. Mixing alcohol with benzos or alcohol with other recreational drugs, each one gets a point. Alcohol level over 200 or increased autonomic tone. All those things get a point. If you have at least 4, it's considered positive. Mortality in DTs less than 5% as compared to 37% early in the 20th century. If they die, they usually die from complications of alcohol, such as if they get in a car accident or they have head trauma, arrhythmias, or they have complications of what forced them to stop drinking in the first place to throw them into DTs, things like hepatitis or pancreatitis or GI bleeding. And then while they're in-house, if they're older, if their temp is over 40, if they have pre-existing cardiopulmonary disease or pre-existing liver disease, they're more likely, they have a higher mortality. I don't like CWA. I just don't like it. I'm sorry. There are 9 items on the CWA scale that are graded 0 to 7. And then orientation is graded 0 to 4. So there's a max score of 67 points. And everything is graded 0 to 7. So for example, agitation is graded from 0 to 7, but anxiety is also graded separately 0 to 7, and tremor is graded separately 0 to 7. So you can imagine that what one person thinks is a 2, another person thinks is a 5, and at a 67 points, 20 is a relatively low score to call it complicated, to call it severe withdrawal. So I'm not personally a fan of CWA, but there it is. Hypo, everything with alcohol, right? Their volume depleted, their K is low, their MAG is low. Both hypomagnesemia and hypokalemia predisposed to arrhythmia. Hypomagnesemia also predisposing to seizures. They're usually hypophosphatemic at baseline because they're usually all malnourished at baseline. My treatment for alcohol withdrawal is always pretty straightforward. I give lots of fluids. Very few things in medicine I don't give lots of fluids for. But IV fluids, nutrition, you give glucose and thiamine to prevent Wernicke's, folate, thiamine and folate, 90 and 80% respectively. Alcohol, 90% of people in the hospital with alcohol-related disorders are going to be thiamine deficient, 80% are going to be folate deficient. There are lots of other vitamin deficiencies, but none as high as these two. So we give those, we replace electrolytes, we give benzos, we put them in a protective environment, and chemical restraints are safer than actual restraints, right? Actual restraints puts the patient and the caregiver at risk. And there's not a person in this room who hasn't been kicked or punched by somebody on something. So, Valium and Librium would be the preferred agents because they have a longer half-life, so they're smoother, they're better at preventing seizures than Ativan is, but they're technically contraindicated in anybody who's got hepatitis or cirrhosis, so all of our patients have hepatitis or cirrhosis, so the problem there is that the side effects of the longer-acting benzos are less predictable, so Ativan becomes really the drug of choice. I'll put somebody in the house with alcohol, I'll put them on fluids at 100 or 150 an hour. I didn't start giving thiamine IV until I started working at Laguna. I'm sorry to say that. We have patients at Laguna that have an altered sensorium, and whether you want to actually diagnose them as having Wernicke's or not, after 4 or 5 days, we'll punt and put them on thiamine for a couple days and they'll get better. So depending on, now not every patient with alcohol withdrawal, but if I put somebody in the unit with alcohol withdrawals, if I think they're likely to have complicated withdrawals, I'll give them 6 doses of thiamine, and then separate from that, I'll put them on thiamine and folate once a day. You got to let them eat, they need nutrition. And I write for Ativan 1 to 2 Q4 PRN. That's what I write, that's all I write for. I write for 1 for agitation, that's 1 to 5, 2 for agitation, that's 6 to 10, and this works 9 out of 10 times for me. So about 10% of the time I get called and the nurse yells at me saying, what are you doing? Well, can I have more, please? And I always say, yes, of course you can have more. But this works 9 times out of 10. I just feel like we tend to over-sedate patients. We do have patients upstairs, again, most people in this room have been called at midnight for somebody who's not breathing because they're on Neurontin 3 times a day and they're on Librium 4 times a day. Not PRN, those medications are scheduled, but then they also have Benadryl PRN and Vistral PRN and Ativan PRN and Soma PRN, and it's a little crazy. So I'm not a fan of over-sedating people. I think that if you put them on a basic regimen of fluids, sorry about that. I think if you put them on a regimen like this, it's, like I said, it's effective for me 90% of the time. You can add phenobarb, 1 dose, 130 or 260 milligrams IV or IM. Up-to-date quotes a study that compared 1 dose of phenobarb plus Ativan versus Ativan alone for ICU admissions, and the incidence of ICU admissions went down from 25 to 8%. You can add propofol. It antagonizes the same excitatory amino acids that we were talking about, like glutamate. I'm sorry, yes?
You want me to go?
Oh, do you mind? Thank you, May. Sorry. One of our colleagues. So you can add propofol. It antagonizes the excitatory amino acids and also opens the GABA-dependent chloride channels and performs the inhibition that GABA is supposed to be doing. Precedex is frequently used in place of propofol, but it's not proven. It's very expensive. It causes hypotension. Everybody knows once you get to 0.7, you got to intubate people. So propofol is recommended. Precedex actually is not. And I'm not saying Precedex doesn't work. I'm just saying that, technically speaking, the mechanism of action for propofol looks better on paper. Drugs to avoid. I've never seen alcohol used for alcohol withdrawal, but it used to be. It's clearly inferior to benzos. Beta blockers will improve their heart rate, but not really anything else. It won't prevent seizures nor DTs. Antipsychotics are usually contraindicated with alcohol withdrawal. Things like Haldol will lower the seizure threshold, interfere with heat dissipation. Now the caveat, of course, is if they're schizophrenic, if they have a psychiatric illness and they need to be treated for an acute psychosis, of course you treat them. Anticonvulsants, again, are the overwhelming majority of seizures from alcohol do not need to be treated with anticonvulsants. If you have status, you can use phenobarb or propofol. They'll work well there, but again, you use them while you're looking for another explanation because it's usually not alcohol. Baclofen's unproven, and central alpha-2 agonists, again, like Precedex or clonidine, will not prevent seizures, nor will they prevent DTs. If you want a prophylax, you can give Librium 25 to 100 for just one day, and then a lower dose for another day or two, and that's it. And then if you want to substitute Cerex, that will work equally well. One case that I read from the New England Journal earlier this year, 54-year-old gent, a half to a whole gallon of vodka a day. He decided to stop. He woke up 10 hours later. There are his complaints: headache, nausea, auditory hallucinations. He was tachy, hypertensive, mild tremor. Phenobarb was given apparently as a single agent because it's Mass General. So, and they gave Topomex for the alcohol cravings. He was clearly better, was waiting to go to rehab a few days later. On day 5, he became lethargic again. He was tachycardic, tachypnea again, but his labs were still normal. He was hydrated, he was better. The next morning, he was bad again. But the next morning, all of a sudden, now he had nausea, vomiting, dark brown emesis, melanotic stools. Then he had bicarb of 18. His creatinine was 0.7, went up to 1.24. His lactate was at the upper limits of normal, but it was half that before. Ketonuria, ABG, head CT, ammonia, chest X-ray, EEG, all normal. So the New England Journal case discussion centered around anion-gap metabolic acidosis. So it wasn't lactic acid because for most of that 5 days it was normal, and even that morning it was at the upper limits of normal. It wasn't ketoacidosis from either alcohol, diabetes, or starvation because he hadn't had alcohol in 5 days. He had been eating that whole time and he wasn't diabetic. His creatinine was 1.24, but he wasn't in renal failure. So it centered on drugs or toxins. So any thoughts on the culprit here?
The GI bleed?
Well, as to what was the culprit for the GI bleed and everything else? Hand sanitizer. So he was drinking the hand sanitizer in the bathroom. So, hand sanitizer can have up to 70% isopropyl alcohol. And in this case at Mass General it was 63%. So it usually doesn't cause an anion-gap acidosis like methanol or ethylene glycol, and it's not as severe and not as deadly.
That's
But it
why
can
they make
be.
it really bitter nowadays. It's extremely bitter.
Is that what they do?
That's why they do it now.
That's a good
I had a
idea.
patient did the same thing in my hospital.
So anyway, so we can explain all these things. And then, so that my last point is just that there are a lot of things in our house that have plenty of alcohol. So, there are some versions of NyQuil that are 25% alcohol. So, patients come in and say, Doc, the medicine you gave me last week didn't work. The NyQuil worked pretty good. I'm not surprised. So NyQuil, not all NyQuil, but NyQuil can be 50 proof. So anyway.
Wow.
All right. Questions?
Yes, I'm Debbie Motley. I'm a certified nutrition support clinician, have been for almost 30 years. And I have Dr. Bay with me. Over there. He's my backup for questions. And then another colleague of mine, Fran, she's going to follow up. In keeping with jokes, what does PEG stand for? Please explain goals. Which is quite appropriate, right, in the ethics world. So I want to compare and contrast transgastric jejunoscopy tube versus gastric tubes. But really focusing on patient selection for home nutrition support. Decisions about the route and access device for infusion of home enteral nutrition should be made early in the discharge process. And the access device should be one that minimizes the risk of complications. Long-term enteral access devices include the percutaneous gastrostomy tube, IR-placed PEG tube, and then this tube right here, which is a jejunal tube. Dr. Christian, will you hold that? So gastric tubes are preferred for several reasons. And that is that this one here has about a 70% complication rate. Reason why, this is a 16 French tube. There's a tube within a tube that's feeding into the jejunum, and it's about 6 French. It's the one with the 3 ports, and there's a balloon that holds it in place, and then there's little ports for decompression, for simultaneous decompression. So you can feed in the intestine, and you can decompress the stomach. So, compared to jejunal, gastric tubes are easier to place and replace and are larger gauge with lower incidence of occlusion. In cases where this tube might be indicated are gastroparesis, ileus, gastric outlet obstruction, significant gastric reflux, chronic pancreatitis, small bowel feeding. In that case, small bowel feedings are a good alternative. But remember that when the stomach is bypassed, the small bowel is sensitive and generally doesn't tolerate bolus feedings, as it doesn't have the pyloric sphincter to help regulate passage of nutrients. So in this case, we do a cycle pump of 18 to 14 hours. I've seen 125, the literature up to 160 mLs an hour as tolerated. So trick question, where do you bolus on this one? All right. So now a patient is being discharged with transgastric jejunostomy tube. A pump is indicated, as it would be for any other intolerance issues, such as chronic aspiration, gastric feeds, dumping syndrome, or chronically poor glycemic control. Again, a feeding pump is considered a medical necessity for home enteral infusion when a patient is going home on jejunostomy feeds. Granny? Now we're going to switch to home enteral long-term access to short-term access in the med-surg unit.
And where are you, Debbie, advancing your slides?
That's yours.
That's yours.
Okay. So, long-term critical care nurse for me, now working in IR for the last couple of years. And so the reason that we want to talk to you about small bore feeding tubes today is because a significant amount of med-surg patients were being sent to IR for small bore feeding tube placement in 2018. When patients are sent to IR for these tubes, they get exposed to a tremendous amount of radiation. Because we use fluoroscopy, it can be upwards of something equal to 70 chest x-rays or more easily, depending on how difficult it is to place. But also it causes a delay in the amount of time that it takes to get the patient from placement to actually feeding, just because of IR schedule. Some of these patients can't even be placed until the next day, and that's not unusual. So, where am I going here? So, what we found is that Doppelhoffs can also be placed with the CoreTrack navigational device, but this is only going to be done in the ICUs. RNs can place these tubes at the bedside. So we did there was a survey done. Most of the RNs in the med-surg units thought that they weren't allowed to place small bore feeding tubes, that it required some sort of competency or extra advanced skill, which is not true. It's like passing any NG tube. The other misconception was that all feedings had to be post-pyloric, again, which is not true. So we did some house-wide education in November 2018 about placing tubes with the benefits of gastric feedings and also indications of when it did need to be post-pyloric. But this is what we found, is that referrals to IR for small bore feeding tubes are actually increasing. We continue to receive inappropriate referrals for small bore feeding tube placements. So we did a chart review of 25 cases, and it showed that approximately 60% of the patients that were coming to IR could actually have been avoided. So the recommendations are first to please make sure that post-pyloric feeding is actually indicated for the patient. Gastric feedings are more physiological, they're easier to initiate, they're more convenient. And post-pyloric is indicated mostly for patients who are at high risk for aspiration or injury. So these are patients that already exhibited aspiration, have recurrent emesis or decreased gastric motility. Obviously are critically ill patients due to their underlying illness or frequent findings of gastric ileus. So refer to IR when there's an inability to pass using the core track device or they have facial trauma. And the other one definitely to send to IR is if they've had gastric surgery, lap band, bypass, that sort of thing. Patients with significant coagulation abnormalities or acute esophageal varices may also come to IR. But these patients may actually not even be candidates for small bore feeding tube placement at all, just because of the risk for injury. So the recommendations ensure that really truly needs to be post-pyloric, encourage the nurses to place the tubes themselves. A KUB, I know it says a chest x-ray up here, but we really need a KUB. We need to see the distal end of the tube to confirm placement before starting any feeds. And also, just a last thing for pancreatitis. The Aspen SCCM guideline regarding small bore feeding tubes for pancreatitis states, it suggested that enteral nutrition be provided to the patient with severe acute pancreatitis by either gastric or jejunal route, as there's no difference in clinical tolerance or clinical outcomes between these two levels of infusion. However, in the presence, measures should be taken to improve tolerance, which might include diverting the level of infusion of EN more distantly in the GI tract. And this is one of the practice alerts that was sent out to the nurses. It's still available for them. Any questions?
If you have a patient with gastroparesis, is a small bowel follow-through required to make sure the jejunum is clearing before you put a J tube?
That would be not a question for my scope.
Small bowel, so here's the thing. The question is whether to put an NG tube or gastric feeding versus jejunal feeding.
No, it's whether to do a jejunal follow-through before you put the J tube because you've got gastroparesis already.
So to get to your point, the main thing is that it sounds like there's some randomized controlled trials that have done before, didn't really show significant, and there's some mixed results. A couple studies show that the aspiration pneumonia does not increase with G-tube versus J-tube, but versus one study did. So right now, it's not really sure whether bypassing the pylorus will really prevent you from aspiration or not. So if there's no clear reason, G-tube should be fine, or gastric feeding. Now, clearly some conditions like gastric outlet obstruction, severe gastric paresis, not by symptoms, but that documented ejection fraction extremely being low, and scleroderma, dysmotility, esophagus. Person with 6 centimeter hiatal hernia, obviously he's going to regurgitate. And to get to your point, yes, sometimes doing a contrast study to make sure there's no gastric obstruction might be useful. But before that, you should probably know that someone has gastric obstruction or not. In those patients, definitely post-pyloric is warranted. Now, whether there's a difference between post-pyloric versus all the way to the jejunum. Now, jejunostomy tube, the nurses cannot really get there. Post-pyloric, the ICU nurses can. So if somebody has a stroke and cannot swallow, that's not an indication to put a jejunostomy. If there's no history of severe reflux, if there's no history of aspiration, stomach's working fine, NG tube should be fine. But if he has 6 centimeter hiatal hernia, she's been admitted for multiple aspiration pneumonia, then definitely it should be post-pyloric tube, which can be put in by ICU nurse. Someone with acute pancreatitis, severe pancreatitis, like you said, yes, it's controversial. I mean, to be honest, there's no clear study that shows oral versus NG versus NJ tube any benefit in any one of these routes. So to be honest, if patient can tolerate feeding, go ahead, feed him. But as everybody has seen, if things go bad, pancreatitis can go really bad. So right now, I would probably be more conservative. If someone meets the SIRS criteria with acute severe pancreatitis, out rather do a nasojejunal tube, which can be done by the IR.
Thank you,
The whole
guys.
goal just being to get them fed faster and fed easier if we can.
Yeah, and just the one thing about if you do jejunostomy tube, make sure the pump, because remember you're dumping food directly to the jejunum. You don't have that reservoir like a stomach, so you want to get the pump ready before you send them
One
out.
quick question for both of you. So in all the big programs, they started using this new device for PEGs and IR, which is a magnet that goes down, and then they do it on the ultrasound instead of doing the 70 X-rays. The Lempert look into that, because Qureshi just went to a conference and they started looking at.
So
all
not
the
for
university-
PEG, right?
For GJ and PEGs, they have this new device where the patient basically swallows like an NG tube that has a magnet at the bottom of it. And then the magnet, you put another magnet from the outside with the ultrasound assist, and then the IR does a procedure that way. It's like
I haven't seen that yet in our
it's kind of a
practice.
neat device, yeah.
So something to bring up with Dr. Levert. Yeah, but they are doing pull-throughs as well as the percutaneous
I'm Dan Penisville. I'm one of the critical care docs with Heritage. Been here, been practicing for about 12 years, been at Mission for about 8. And it's impossible to give you basically all the updates on sepsis over the next, Raekwon gave me 8 minutes. That's a little impossible, but I'm going to try to do my best. I have no disclosures. Everything that I'm going to give you today is basically right off of the last conference, CHEST and Critical Care Medicine. I actually wanted to get the actual slides that I have on my phone and be completely lazy and not do any PowerPoint and just pull it right up, but I was so incompetent I couldn't even do that. So, every slide, this is not my opinion. This is just standard of care. This is right out of the conferences. So this has nothing to do with what I feel about the topic, how I work, how I do it, or whatever. It's 100% out of the critical care conference and out of the CHEST conference that meets every year. I go to one conference a year, and at the end of the conference, they give you a thumb drive with all the lectures that you can download, but you can't really duplicate the slides. So you have to actually copy, paste, picture. We were talking in so many, but so this is a real thing. I know that there's a lot of times talks amongst the hospitalists that have the hospital, everything is sepsis, everything is sepsis, the hospital's buying everything is sepsis. There's like some conspiracy theory, right? No, the Russians are not gaming the system with the hospital. They're not upbilling, they're not upcoding, there's no mortality O to E. I know, Cullen, we've been on the same committee for the last 4 years for sepsis. There is no Russian conspiracy with the hospital. It is a real life-threatening organ dysfunction, secondary to a dysregulated host response, right? 270,000 people die every year of sepsis. It is a legitimate concern. MI gets respect, right? You do door to balloon in an hour and a half. Stroke gets respect, right? When somebody comes in with a stroke, everybody's like, oh my God, we got to give TPA within that hour, within that 4.5 hour window, right? But why shouldn't your septic patient get antibiotics, right? So that's just something to keep in mind. So what they started looking at, my presentation is basically on 4 things, right? I kind of wanted to focus on the real nuts and bolts and the updates of sepsis. And things that they looked about at all these conferences and all the lectures that I went to during the meetings were fluids, antibiotics, protocols, steroids, and pressors. So I kind of want to just give you bullet points of each major topic, because each of these topics, they spent hours of lectures, right? But we're going to try to do it in 10 minutes. So I'm just going to give you like the highlights of each one without diving too much into it. So what they looked at is, interestingly enough, is that every septic patient that came in that either died or got discharged, they started doing this research and they started looking at immunomodulators and they started looking at interleukin-6 and all this stuff, right, that we used to learn in biochemistry and all these inflammatory markers and biomarkers and all this stuff. They looked at that these septic patients actually that die of sepsis have higher immunohistochemical findings compared to patients that are not septic. So they showed that the inflammatory markers at hospital discharge are higher in these patients that die of sepsis or are discharged after pneumonia or septic and they go home, and they looked at the IL-6 in particular and they saw that the levels of these patients post-discharge were a lot higher than the patients that were actually non-septic. So in the future, what they're proposing to do is looking at these in real time. So then you can make a judgment on which patient's going to come back from the community with these high markers that are high risk of dying, and which patients that are already in the hospital with these high markers that are high risk of dying, right? So down the pipeline, they're really looking at really giving you this in real time. What do we look at? One of the things that we look at in the hospital is procalcitonin. But there's this misconception that people say, oh, the procalcitonin is normal, don't do anything, don't treat it. No. Why aren't we using procalcitonin on everybody to start antibiotics? We get it on everybody because it's on our order set, it's part of the protocol. I don't want you to misunderstand the use of the procalcitonin. Just because it's negative in the ER, that doesn't mean the patient's not septic. The procalcitonin can be falsely low. So just because your first one in the ER is negative, but your patient is septic, don't say, oh, I'm not going to do anything. Let's not give them antibiotics and move on, right? You delay antibiotics, the patient will die. So don't go based on the procalcitonin that's negative, not to give them antibiotics. Prior administration of antibiotic on a previous hospitalization, when they come back a second time, the PCT can still be low. So don't let that fool you. It's not a standalone test. Just because the procal is low, that doesn't mean don't do anything. Delay the antibiotics, right? Bundles have been shown to decrease mortality. A lot of you are going to be like, oh, protocols, they don't work, and this, that, the other, blah, blah, blah. What we're stressing about bundles and sepsis, it's about the fundamental of sepsis. Antibiotics and fluids. That's never going to change. It hasn't changed in 10 years. It probably will never change. You have to appreciate the fact that every time you delay antibiotics by an additional hour, your mortality significantly goes up. And for me, 4% is a lot. I don't know about you, but if I was hospitalized and a G in my name withheld the antibiotics from me when I was septic on the PCSC, I would have killed them. What do you guys think? You know, like, don't hold antibiotics. Now, going so broad is a different debate for a different day, a different argument. Not everybody should get vancomycin. We all agree with that, right? That's not what we're discussing here. You have to give the right antibiotics at the right time. Right? Don't give vancomycin to everybody. That's a discussion for a different day. But you have to give antibiotics. If somebody you think is septic, absolutely do not withhold antibiotics. The delay is staggering. They looked at all these like 50, 60,000 cases in New York. The whole sepsis concept all started because of one kid in New York City died. There was a pediatric case that started this whole bundle and this whole sepsis thing all over the country because 10 years ago, and I have a photo of the kid on my phone, but I can't show you up here, and I wanted to put him up. But anyway, and his parents just went ballistic on the hospital. And that's how they started the whole initiative after this kid died in New York City with bundles and the 3-hour and the 6-hour, and the state of New York started all this, and then it kind of carried out to the rest of the country, right? But they even showed that the patients that got the bundle in 3 hours and got it in 2 hours did worse than the ones that got it in 1 hour. So every hour delay in completing your bundle and your antibiotics is very, 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 very significant. Procal's level can be used for you to de-escalate antibiotics and to discontinue antibiotics. But you never want to go based on a procalcitonin level to start your antibiotic. You don't want to hang your hat on that. But let's say you have somebody in the ICU and you thought they were septic, but maybe they're not septic because they're pancreatitis and they're alcohol withdrawal and their white count's high, and you start antibiotics and you get your Procal on day 1 and it's negative, but you start antibiotics and then day 2 and 3 it's still negative. Now you can say, okay, I can stop him. He's not septic. There's something else going on. Let's de-escalate the Procal, the antibiotics, and let's move on, right? So what's the rationale of PCT? The severity of your sepsis and the mortality. How many times have you seen a Procal that's like 200? The nurse calls you and you're like, oh, it's 30. You're like, oh crap, this patient could potentially end up dying, right? Which patients have you seen in your experience do the worst? The ones that really, really have the really high number, right? So also, why else would you use the PCT is also for poor source control, right? Let's say you got them on vancomycin for a cellulitis, right? And you get your Procal the second day, because the first day is negative, the second day is high. Then the third and fourth day keeps going up, and you're like, oh, wait, there's a problem here. It should be going down, because you should be achieving source control, and your Procal should be going down. Now you're thinking, oh, crap, maybe this is deep, it's neck fash, I don't have clindamycin to this, I don't have source control, maybe I need to get a surgeon, I need to get imaging. So now you're thinking your Procal's going up, you have a problem. Or the patient develops diarrhea. How many times they get C. diff, right? They develop diarrhea and you're like, damn, everything looks good, the white count's more than anything, but the Procal keeps going up and up and up and up. They have diarrhea, and now you're like, oh crap, now I gotta treat for C. diff. This is my Procal, and that when it keeps going up, that means you have inappropriate therapy or a new infection. So you want to keep that in mind because you might have poor source control or a new infection. Or like we talked about a minute ago, you have somebody who wasn't clear, he came in with pancreatitis, you weren't sure if it was necrotic, you put him on antibiotics, and the Procal just stayed 0 for the next 3 days. Crap, at that point you might as well stop it because now you can de-escalate your antibiotics because you have proof that it wasn't sepsis and you were just caught off guard because you were trying to be safe and you didn't want to withhold antibiotics in case it was, but now you can de-escalate because your Procal has been negative, right? So the why do we use a Procal is because given vancomycin and meropenem to everybody, eventually it's going to lead to rising rates of MDR, so that's not the right thing to do. If you could de-escalate antibiotics right away using the PCT, you want to use it because C. diff is a real thing. MDR is a real thing. Stewardship, antibiotic stewardship is a big thing now because we're always constantly trying to hone in on the right antibiotic at the right time and trying to de-escalate and not use all of our antibiotics. If we give everyone vancomycin meropenem, eventually we're going to run out of things to give and we're going to have a high resistance. So that's why you want to look at your Procal and kind of follow that. Now, there's pros and cons of anything that we do in medicine, right? A lot of people like guidelines and protocols and checklists, and a lot of people don't. But the reality of the matter is, do physicians perform better when we rely on clinical judgment? Is there variability in care? And how close are we to precision medicine for critically ill patients? Right? Why do we have protocols? Because a lot of times it just reminds us to complete all the elements that a sepsis bundle may have, the lactate and the blood cultures and the urine culture, and give the antibiotics at an appropriate time and try to avoid a lot of discrepancies in the cares amongst the physicians. But unfortunately in medicine there's a wide variation in care. And I always look back and but I used to do it this way and my experience has been and this, that. So all the studies at the conferences, they all showed that unfortunately no matter what, as the physicians get older, our care doesn't get better, but it gets worse. And that's why sometimes we need to remind ourselves of protocols and bundles and things. It's not because we're become more experienced and we can become less efficient. It's become, as time goes on, some people do go to a lot of conferences, some don't. Some people keep up with things, some don't. Medicine is so broad that it's impossible to keep up with things. So all the studies have shown that physicians, as we get older, we don't necessarily get better. So it's good to have a reminder to have protocols and order sets and things there so we don't have inconsistency of best known medical practice. And sometimes physicians are busy in a chaotic environment, right? I mean, Ray could be sitting there, he can get two things, he could be admitting a septic patient and the Click app is going off twice, and Reza's coming up to him and fist bumping him, hey, what's going on, man? And then Keith was like, hey, did you get that email I sent you the other day? And then Sophia goes, yeah, I made an appointment, and he's here trying to admit these septic patients going, oh, did I put in everything? And then Click keeps paging, bumbling, she's like, what the hell? So he has to multitask, right? He has to do all these things at the same time as he's trying to admit the septic patient, right? So he may miss an element or two, but if you have like a protocol, a bundle, or an order set or something like that. Now, our current order set is, I'm the first one to agree that it's garbage. There's a lot of fluff on there, it's just a mess, right? But the great thing about it is when you use the order set, it triggers a nurse that makes sure one thing only. We tell them, make sure one thing, get the antibiotics in the first hour. Make sure that that patient gets the antibiotics. I don't care. Make sure no matter what you do, you climb over the ER nurse or over that nurse on the floor and you get it. Why is it important? We went over the slide before, every hour delay, an antibiotic, 270,000 people die, right? We went over this at the beginning. So we created this mortality task force also, right? And we look at all the deaths, every septic death. And every time it's the same thing. Like Laguna a couple of weeks ago, 6 hours to get antibiotics in. One of my critical care colleagues, 8 hours for an ICU patient to get antibiotics, right? A couple of weeks ago on the medical floor, 12 hours to get antibiotics in. This should never happen. Why? And it's always the same thing. The nurse wasn't notified, she didn't know, they left it up to the floor nurse, the order set wasn't used. The order set is garbage. It doesn't work. I mean, who was with us all those meetings? Finlayson and Shaquille was at these meetings at Hogue. We all met with Hogue and all the hospital. Nobody could agree on anything for the order set, right? And it took us a year of meetings, 8 hours once a month. Nobody agreed on anything, but we all agreed on one thing: get the antibiotics in within the first hour, right? And make sure that the order set is used for that purpose, so the nurse can actually go get the antibiotics in that patient. Everything else, if you like the cultures, don't like the procal in there, the lactate, everything else, the antibiotic choices, whatever. The important part of the order set is because there's an actual nurse that physically gets called when the order set is used and makes sure that that patient is getting your antibiotics. When you put it in yourself, you're leaving it up to hope that the ER nurse or the floor nurse or at Laguna that they find this order and that they put it in, right? So that's the important thing of. So fluid recommendation. What's the trend now in sepsis? So we used to always use normal saline. Now all these trials have come out, right? The MAKE trial, the SAFE trial. They like to call them all these cute names, right? It doesn't matter what you call it, right? The important point of this slide is that now we have transitioned off normal saline and we are using lactate ringers. Why? Because we have now learned after all these trials that normal saline actually gives you a higher rate of AKI and mortality because it's related to like hyperchloremic acidosis and the kidneys, and Packard can give you all that lecture, right, about the beans. But the bottom line is that LR is much safer in sepsis because we're giving a lot of fluids, right? So LR is the fluid of choice. Some people say, oh, what about if my patient has hyperkalemia? No, the amount of potassium that you're getting in LR is so small that unless your K is 7 already, of course you're not going to give LR, but your K is going to be 4 or 5, it doesn't matter, because the amount of potassium that you're going to get in lactate ringers, 2 to 3 liters, is not going to change your potassium at all. What's going to kill your patient is if you flog them and they end up in AKI, and that's a big problem, right? And then fluid resuscitation still remains the cornerstone, right? But now, here's the thing. Now we're like, oh, how much fluid do we give? And in all the conferences, they say, oh, just give just the right amount of crap. What do you mean just give just the right amount of fluid? That's like, you know, so you're like, oh, okay. And they say, everybody says, avoid under-resuscitating, avoid over-resuscitating. You're like, okay. So, what, you know, how do you get there, right? So then they're looking at, oh, okay, maybe you want to start with like 10 mLs, right? So they say start with 10 mLs per kg and then start assessing your vitals, right? If they don't have an art line in or a swan, and you don't have things like short volume variation or a wedge then, and they're not intubated, you could do a straight leg raise, or you could see if you give them the bolus fluid and you see if their blood pressure goes up, right? So they're saying ongoing debates are still, the current campaign for sepsis is still 30 cc's per kg. So that's what we have in our order set because that's what the Surviving Sepsis campaign says that we have to do. But they're saying, you know, is 15 enough? Or is 30 the right amount? And then they end the lecture and they say, just give the right amount of fluid. Don't under-resuscitate, don't over-resuscitate. So that's why I'm saying the debates are still ongoing, but start with 10 mLs, hang up the first liter, see if their blood pressure goes up, see if they respond, use their hemodynamic monitoring. If they're not responding and you keep just flogging them with fluid, guess what? They're going to end up intubated, they're going to end up in AKI, they're going to end up, mortality is going to be much higher. So over-resuscitating is a big deal, is a real thing. Why vasopressors? The debate is which vasopressor to use. Why vasopressors, right? Because if you remember back in the day, at least for a dozen years ago, they used to say, Levofed leaves them dead, right? Everybody heard that famous now. Levofed is the first line, right? So medicine is constantly changing, and they're constantly looking at data, and they're constantly reviewing everything. But hypotension is a real thing. A lot of times you walk into the ER and you're like, oh, the patient's 60. What are you guys doing? Oh yeah, just getting around to the fluid. And then, no, it's a big deal because when you're hypotensive, your kidneys go, your organs start to go ischemic, your gut goes, your liver. It's like you don't want to keep somebody 60, so you start to press her as you hang the fluids. And the ER's like, oh yeah, we're getting around to that. No. It's a real emergency. Somebody's hypotensive. It's a big deal. It's not like a small deal. Hypotension is a big deal. So you want to get your MAP to 65 and over. You want to consider it a medical emergency. Norepi is a first line, right? And why do I like to just throw it on as you're giving the fluids? Because you can bring their MAP up. And then you might overall decrease the total amount of fluid that the patient needs during the resuscitation by achieving that, just the right amount of fluids, right? So, is it time to add angio 2? I have no disclosures. I don't work for La Jolla. I don't get paid from them. I have nothing to do with them. But this is a new vasopressor that came out about a year ago. And I'm happy to say we have this here at this hospital and we do use it. And I pushed for it at the beginning when it came out and we were able to get it approved. Even though it took 55 letters and 75 meetings, I did get it on formulary and we are using it. So, angio 2 works by a completely different mechanism than your Levofed does, than your dopamine does, than your epinephrine does. All the other pressors work by a sympathetic system, and they vasoconstrict that way. Angio 2 works by the renin-aldo Angio 1 to Angio 2 to renin-aldosterone system, and it vasoconstricts in a completely different way. Now, does it lower mortality? And Athos 3 trial put them on the map with getting to your 65 map within minutes. I tell you, if you're ever at the bedside and we're using this drug, you stand there and you're like, oh, how are you on levo, vaso, epi, and all these drugs, and then you start Angio 2 and everything just melts off. And they achieve a map of 65 and all the other drips coming off within minutes because it works by a completely different mechanism that the other drugs work by, right? Has it shown mortality benefit? No, I'm not advocating to use it on every single patient. And even at the conferences, Perolo and all the big guys at the big time universities, everybody's using this. But nobody is advocating to use this as second line or first line. Everybody's using this as third line right around the country. And some programs are using it on second line. But you have to appreciate the fact that there's a subset population in the septic shock patients that end up on CRRT, that when you use Angio 2, because it is a kidney, right? It is within the kidney, we use ACE inhibitors, and we all know this, and it goes Angio 1 and 2. This is basically a hormone. It's a genie in a bottle because it is a hormone in a bottle, basically. And we're using our natural system to help us fight and increase our blood pressure, right? So what I found shocking is that they looked at all these patients with renal failure, and these people that were on CRRT came off sooner when they used Angio 2 versus the patients that didn't, right? So, is it time to use it on everybody? Probably not. Is it safe in patients that have a low cardiac output? No. I've seen it firsthand. One of my colleagues has used it on somebody with a low cardiac output, they had a cancer patient, and she didn't do well at all, right? Had a massive MI. It was just catastrophic. No, that's not the right time to use it. What we learned through the last year of using this drug, and part of the previous trials and the Athos too, somebody that has vasodilatory shock on multiple pressors that has a high cardiac output, this drug is safe to be used on. High cardiac output. Low cardiac output, not so much. You probably don't want to use it. Is it superior to other agents? No, we don't know that yet, right? In the subgroup analysis, did they show that the CRRT patients got liberated sooner and they had a higher survival rate? It did show that. Are we saying it to use it on everybody? No, they're just saying they need additional studies. Have I seen it firsthand? I cherry pick the patients that I use it on. I like the Rezas of the world, okay? I don't like the 80, 90-year-old patient coming in with a ton of comorbidities, right? I like to use the 50-year-old that's relatively healthy, that doesn't have a ton of comorbidities, it's not a complete disaster, right? And they come in and they're in fluoric shock, and they go on CRRT, and Packard has seen it there, we throw them on CRRT, and you're like, oh man, now you're committed to CRRT. Who wants to go home on CRRT, right, for 3 to 6 months? Maybe the nephrologist do, but not the patient, right? I mean, maybe they want more business in their dialysis center. In 12 years, I've never seen a patient prior to this year leaving the hospital that I personally put on CRRT in the ICU leave hemodialysis free. And we've had 4 or 5 patients, and probably some of you in the room that had patients with me, that went home off dialysis. And we started CRRT in the unit. They got 1 or 2 rounds of HD. Most of them actually didn't even need hemodialysis. We stopped them right from CRRT. They started making urine, everything was great, but I've never had a patient prior to this, to using HD, go home that started off on CRRT and HD that went home without requiring HD. So that's what they're just saying. It's something to keep in mind for that very exclusive subset population, for the healthier ones that end up on CRRT that you want to use Angio 2 on, right?
Karen, sorry to interrupt. Time check.
Oh, okay. We don't have much left. And then there's a benefit in the cardiac surgical vasoplegia patient, right? And then this is the last slide. And then at the end of all the conferences, they're like, the ongoing debate is to be or not to be, right? To give steroids or not to give steroids. Now, Bruce always says, oh, give steroids to anybody that's dying. Nobody should ever die with steroids. No, that's not true. Don't listen to that. That's we make stuff up like that in medicine sometimes to be cute and fun. But steroids is a big deal. So they looked at all these trials and they looked at everything across the last decade. And even the surviving sepsis campaign that recently was revised in 2018. Yes, give steroids in somebody that's in profound shock, multiple pressors, that you've given appropriate fluid resuscitation, and that's fine. But don't give steroids to every septic patient that comes roaming into the hospital. And even that is only a grade 2C recommendation. And still, to this year, it remains a grade 2C recommendation. Nobody's going to fault you for giving steroids, but you don't necessarily have to give steroids in septic shock. Okay. Question? Yeah.
I have data for you, and I'm not going to go through all the data slides because you have a copy of it. My name is Kathleen Stowell. I'm the Senior Patient Safety Risk Manager with the Doctors Company. We have probably the most rich database on closed malpractice claims for every specialty, but especially for hospitalists, because we have had since the very early, I've been with the company over almost 13 years, and when I came to the company, we had 2 of the largest national hospital accounts. And so we have, everyone comes to us for research. And so what I'm going to share with you today, I don't have a joke, but I have, wait, this is it, Groucho Marx. Learn from the mistakes of others. You can never live long enough to make them all yourself. This is the best slide of the day. What I want you to take away from today, and I am so happy to follow Doctor's sepsis talk, because this is speed dating. I'm going to speed it up, Dr. Claw. We had 2 different studies we did. One was 2007 to 2014. It was a 7-year study of closed hospitalist claims. Then we thought, we don't want to wait that long to do more studies, so we're going to do a study that was from 2015 to 2018. It was only a 3-year study. We just wanted to see, well, how is hospitalist medicine changing through malpractice? You know what we found that's really important, especially following your beautiful presentation on sepsis? In the first study, sepsis didn't even show up in the malpractice claims. It was way low. Wasn't in the top 25 things. You know where it is today? It's number 3. And you know what it's behind? Death. Okay, death. People just die. You know, we get people who have a lot of comorbidities. We get the 89-year-old person who has all these things. They're going to die. So cross that off. What's next? Cardiorespiratory arrest. Okay, those are the people that end up dying. So they sue, and the allegation is you didn't diagnose the death? No. The thing that comes in with a misdiagnosis or poor management, number 1, numero uno, sepsis. Sepsis kills people. The antibiotics, I cannot tell you. Now, what I wanted you to know that our study shows is what are contributing causes? So why? Why do hospitalists, is this your big nut to crack? Delay in diagnosis, delay in treatment, or mismanagement. That's like one thing. Delay in treatment / mismanagement. Why? We didn't get antibiotics fast enough. Don't be held hostage by protocols in your hospital and who you're dealing with. You go and pound the table to your CEO and your chief medical officer and say, this is not negotiable. You're going to be on stroke protocol in the ER. They're going to have you on, TPA. Everybody's right on it. That's how antibiotics have to be. And I share that based on a lot of analysis of the claims. The other contributing factor that we see, communication. And it's not communication with the patient, by the way. You know that? You know who it's with?
Colleagues.
Who?
Colleagues.
Colleagues. You're not communicating. You're not communicating. Primary care doesn't communicate with specialists. Specialists don't communicate. And the third thing is a delay in a referral. Don't try to hold on to these patients. If you're a hospitalist, think about, should I get an infectious disease consult? Should I get a specialist? Delay in getting a referral is the big one. That's the third of the 3. So a couple of things I want to show you. We're not going to talk about this. We don't care about that. The rates of claims, I do want to tell you, look how you've gone down from 2006. But in 2018, you went up to 13%. Why? Sepsis. Sepsis is your nemesis. The rate of internal claims, I just wanted to show you this because a lot of internal medicine become hospitalists, and you have any comparative peer group. So I just want you to show that you're higher than they are. Doesn't mean they're better, it means they aren't getting sued as often as hospitalists. On the other hand, do you want to know what? In the last 12 years, hospitalist frequency of malpractice claims has dropped dramatically because you're doing a great job, but frequency's up. That's just my, so I'm not going to look at that. You can read these slides on your own. You can see what we paid. But look at this. There's a 39% increase in indemnity. That means they're more expensive. That's why I say severity's up. People die or they're permanently disabled or they can't work again. We have younger people. If you look at the age range, we have younger people. The younger people who have a disability or die and can't provide for their family and can't work anymore, a lot of those claims come from sepsis. Of course, the nightmare claim, spinal epidural abscess. That's not a program on this today, but I have a program on that. Patient injuries, I want you to see here, our most recent study is on the right, 2015. I just wanted you to see, not only is sepsis there, look what's underneath it, infection. Infection before it becomes sepsis. Adverse reaction, you know what that is? Adverse reaction to meds. Medications is the fourth thing that's your nemesis. Why? Because you're not getting good medication history. Your medication reconciliation is not including, oh, are you asking your patients they use cannabis products? They're legal now in states where they are and you're giving them things that could be drug-drug interaction? Are you asking them if they use any recreational drugs? You need to ask people this. Everybody should be asked this in your offices as well, for anybody who's not a hospitalist. Because this is where we're finding, people lie, you know, patients lie. Their families lie. You don't lie. You tell the truth. But if someone asks you, are you using cannabis products or recreational drugs, would you tell the truth? I don't know if you are or you aren't, but you decline. At least then you can write that the patient declined any recreational drug or cannabis products. However, when they sue and they get the records and they find out that the patient was using, then they blame you because they say you didn't have a thorough medication reconciliation. We're not going to look at these graphs, it doesn't matter. I talked about the top kinds of claims, diagnosis related, and that's a failure or a delay in the diagnosis, improper management. I want you to see that the red numbers are from the older study, and look where we went up in 40%, everything else kind of stayed about the same. Improper medication management went up by 5% in the 3-year study. Now, it's a smaller claims pool, so you know, we can make statistics say anything, but we do see recurring increase in medication mismanagement of medications because we didn't get good history on the patient. I'm not going to go through these. These are just final diagnoses, people that sued. What did they end up having? And I think it's important to see that. Who are these people? And they're small percentages, but claims with diagnosis-related allegation. That means they sued because of you missed or mismanaged or failed on this diagnosis. That's what this slide shows. And the percents aren't high, 5%. It's not a lot, but I just wanted to at least show you that because I did want you to see intraspinal abscess is number 2. We're not going to do a case example. You can read that. Wait a minute. These aren't the right... I sent the wrong slides. I'm sorry, Georgina. This is the slides I showed you are taken from this is a longer case. So I'm done. Because the claims you have in front of you end with the lessons learned. And the lessons learned, of the lessons, I'm not going to go through it. You just have a full slide set here. The most important thing I want you to take away today is antibiotic. Immediate, when you have a sepsis concept in mind. The other thing is consider a differential diagnosis. If you just do that, you'll do better and have a less chance of being sued. Because what we find in our malpractice experience is there is no differential diagnosis. You get the patient through the emergency room or they get admitted by primary care and you're like, what they said is what it is. It's not always what it is. It's not always what it looks like, what it smells like, what it sounds like. So you really want to think, what else could it be? And be a curiosity seeker. What else could it be? And if you talk to your colleagues, remember there's no such thing as a curbside consult. So don't document that I spoke with the nephrologist who said such and such. No, he didn't see or she didn't see the patient. So remember there's no such thing as a curbside consult. You can talk to people about things, but there's no such thing as a curbside consult. To have a patient-physician relationship, the physician that you talk to would have to examine the patient, see the patient, look at records, and bill for the patient's care. So with that, I would like to leave you with my last thought of the day, which is words are, of course, the most powerful drug used by mankind. You have heard a lot of words today, but I just want to thank you for inviting me, Dr. Kwa. I'm done. I want you to go on your way. I want you to think about always what differential diagnosis could it be? What else could it be? And remember, ask patients more about the medications they're on. And remember to, if you're thinking about a referral, think about it, then do it. Ask for a referral. I thank you for this time. I know I went really fast, but you have all the data, you can review the slides. Yes, sir.